Hi guys, today's topic about facial nerve trauma. So this facial nerve trauma, the most common cause of the facial palsy is the Bell's palsy, about 70% of the cases. And second most common cause is the temporal bone trauma. And third common cause is iatrogenic injuries like ear surgery and parotid surgeries. Now this facial trauma can happen by temporal bone trauma, carotid surgery, or iatrogenic ear surgery, or parotid injury from external compression, or iatrogenic maybe ear surgery or parotid surgery. So these are the common causes. Now I will focus on the temporal bone trauma. This temporal bone trauma divided into initial classification was longitudinal fracture, and second was transverse fracture. In 70 to 90% cases, it is longitudinal fracture, and rest 20 to 30% cases are transverse fracture. Now, what is longitudinal fracture and what is transverse fracture? Now, I will show you in the skull. See, if this is the squamous part and this is the petrous part and this is foramen lacerum, if any line extends from squamous part or mastoid part of the temporal bone going longitudinal to the pyramidal, this petrous pyramid, up to this foramen lacerum, this is called as the longitudinal fracture. Now transverse fracture, if any line passing from foramen ovale or foramen spinosum toward the hypoglossal canal or foramen magnum, so perpendicular to this petrous pyramid, any fracture is called transverse fracture. If you see this line from foramen ovale to hypoglossal or this magnum foramen, you will see there is location of this otic capsule. So this line mainly affect the otic. This transverse fracture mainly affect the otic or labyrinthine portion of the ear. So this transverse fracture having maximum time of the chances of facial palsy are about 70 to 80%. In this transverse fracture, more chances of facial palsy because this is severe trauma. Now, new classification which I prefer, and this is the best for prognosis. One is Otic capsule sparing classification, and another is Otic capsule involving classification. This is same like transverse fracture, and this is same like longitudinal fracture. If you see this, any injury of this petrous which leading to the Otic capsule is Otic involving or which spare the Otic capsule, that is Otic capsule sparing classification. So this Otic capsule sparing classification, most of the injuries like and the longitudinal 70 to 90% are in this group. Otic capsule sparing, because this otic capsule is very hard and strong bone which resist the trauma. And otic capsule involving this injury is just like transverse, about 10 to 15% cases only. In otic capsule sparing, there is better prognosis, there is delayed facial palsy mainly, there is less vestibular symptoms, and conductive loss is more common in this otic capsule sparing trauma. In otic capsule involvement, there is acid loss, poor prognosis, mainly complete immediate palsy. Immediate palsy is there, and there is more vestibular symptoms like tinnitus and hearing loss is common in this otic capsule involving injury. Now, how you will identify this otic capsule involving injury? If you see, CT scan is gold standard in the temporal bone trauma. So, any air pocket or any fracture line going through bony labyrinthine, it means it affected the bony labyrinthine. So, these injury are comes under otic capsule involving injury. These injury are severe injury and suggestive of severe trauma. If you see clinically, these patients having SN loss, more vestibular symptom, and on PTA there is SN loss. And then this more chances of facial palsy because this is severe injury which involving the aortic labyrinthine. This aortic labyrinthine having very close relationship with the facial nerve. That's why this aortic capsule involving injury involve the facial nerve. Now the management of facial nerve trauma, if you see part of the facial nerve which are most commonly affected by the temporal bone trauma. This is internal auditory canal. This is labyrinthine segment of the facial nerve. This is geniculate ganglia. This is tympanic segment. This is vertical part of the facial nerve. And this is second genu. Second genu. So most common injury involving the geniculate ganglia region. So this geniculate injury is about 66%. Tympanic segment about 20%, and this second common is the second genu about 20%. 8% are tympanic segment injury, and rest vertical segment only having 6% injury. Now, if I ask you a question, everyone knows the end of the facial canal. What is the starting point of the facial canal? So geniculate ganglia is not the starting point of the facial canal. Facial canal start right from this the fundus part of the internal auditory canal. It means labyrinthine segment, tympanic segment, and vertical segment all are in the facial canal. That's why this facial nerve is the having longest intraosseous course. So what is the question is? Which nerve having longest intraosseous course? Then answer will be this facial nerve. This is about 30 to 35 mm in length. So this is longest intraosseous course of the facial nerve in the fallopian canal. How to manage? The gold standard is the HRCT, CT scan, then you have to clinically see it is complete immediate palsy or any bony chip can seen in the CT scan. This is absolutely immediate indication of exploration. Second test is PTA for seeing the it is aortic sparing or aortic capsule involving injury. Third investigation you can do electroneuropathy or electromyography. These tests can be done after 3 days because Wallerian degeneration and muscle dysfunction only occur after mainly you can see only after 3 days. And after 21 days, only meaning you have to do electromyography. And you can see there is polyphagic potential, then it means these nerves are regenerating or muscle are going to function. Then if there is no polyphagic potential and there is fibrillation or there is silent EMG, it means you have to explore the facial nerve. After 21 days, there is no meaning of electroneuropathy. So it means between 3 to 21 days, you can do both electroneuropathy and electromyography. In electroneuropathy, if more than 90% fiber are degenerating, it means you have to address the facial nerve. So these are the common tests. Now, what is the management? If any trauma, first indication is the decompression. If it is not, if nerve is transected, then you have to repair it, that is end-to-end repair. And third one, if there is gap, then you can put any cable graft. So it mainly depend on the presentation, duration of injury, and is it immediate or delayed facial palsy. And if any bony chip or complete palsy is there, then you have to immediately explore this nerve. There are so many grafts you can put or you can regenerate this facial nerve. If it is this complete laceration, then you can have nerve graft with the this facial. You take it out from styloid foramen and enjoy with the mesenteric nerve. That is classically very good anastomosis because this mesenteric nerve having 5,000 motor fibers comparable to the facial motor fiber about 7,000. So these recovery and is there very rapid within 3 months, and this recovery having almost grade 3 and grade 2 function of the facial nerve. So this is all about temporal bone trauma. Thank you so much.